Thank you, Lee, and thank you, everybody. I'd like first and foremost to thank all the speakers and to thank everybody for all the work that you are doing. Because at the end of the day, whatever you are doing is helping us, it's improving our lives, and at the end of the day, actually saving our lives. So I thought to start with, let me talk about what critical path to TB drug regimens means for affected communities. I thought I would start with the mission, because the mission really says a lot. For us, when you're living with HIV or affected by TB, everything has to be done in a hurry. So let me talk about accelerate. I'm sorry, I cannot see from here, I don't have my glasses. Accelerate the development of new, safe, and highly effective regimens for TB by enabling early testing of TB drug combinations. For us, that is important as people affected by the diseases. Out there, a lot of people believe TB is the disease of the old, it's gone, and it doesn't exist anymore. But everybody in this room understands that TB is still there, especially for people like me who come from countries that have a high burden of HIV. We have a lot of TB, HIV co-infection. As a woman living with HIV and AIDS, I was once co-infected with TB. And at that time, actually, I didn't even know that I had HIV, so I had TB first. I had extrapulmonary TB, and we know how difficult that is for one to be detected of TB. So for us, when I come to CPTR, it's exciting to know that there's still more research. When I sit at home in my office in Lusaka, I don't know that there are people out here who are doing work or extra research. So for me, when I come here, it's exciting to see that there's so much that's being done. And I'm really excited that when I go back, I'll have something to report back to my constituencies, that there's much that's being done. Also knowing that there are new drugs, especially fixed dose combinations, it's really hard when I'm on second line treatment on HIV, so I'm already taking extra drugs. I'm not taking one fixed dose combination. So for me, if there are new drugs that are coming on fixed dose combination for TB, that is helpful for people like me. Shorter regimens are also good. When I'm on TB drugs, I need to eat more somehow. I used to get really hungry, you need to eat more. So if the regimen is shorter, it saves me on money, because I have to struggle to feed my children, I have to struggle to buy food for while I'm on treatment. So if the regimens are shorter, it helps me in that part, but also on the pill burden. Inclusion of affected communities in the advisory group. This is really exciting. I'm a part of the advisory group. Like we say, we always want to be involved in whatever concerns us as affected communities. So I'm part of that group, and I've noticed that on the stakeholder and community engagement group, there are also people living with, affected by TB. So that's a good plus. And also the release of the good participatory practice guidance for TB and TB trials framework for effective engagement. It's a good guideline, especially that it's a framework that's going to show the engagement of affected communities. And then I also wanted to say, for us, what is happening in this room and what you do out there, for us is a matter of life and death. If what you're doing works, then for us it's healthy and longer lives. If it doesn't, then for us it's really a death sentence. So I thought I should speak a bit around community engagement. I'm here, for example, to bring a reality check. There's been a lot of technical terms, some of which half of the time I didn't understand. So my reason for being here is really to remind ourselves, and also to thank you that at the end of whatever you're doing, there are people like me, a lot of people, we have families. If I wasn't on proper TB treatment, if I had not been cured, maybe I would have died and my kids would have become orphans. I had TB when my daughter was 9. She's now 20 and she's in university. So it's because of the kind of work that you do that really helps people like me. So it's for me to come here and say thank you, and also to remind you that actually at the end of all the work that you do, there's a real person there. And then we also bring first-hand experience with the diseases. Like we always say, even if some of us haven't gone to university, we actually have degrees from the University of Life. Because most of you, for you it's theory, I've lived with the diseases, so there's some kind of experience that I can give you that we can share. So we bring the first-hand information with the diseases because we live with the diseases, we suffer the side effects, so we can share that kind of information. And builds a community demand for and support TB treatment support, treatment literacy. We are advocates and peer advocates at home. In my country, most of the people who are doing in the clinics, you know very well that we have very few human resource in our clinics. So most of the affected communities are the ones who are the defaulted tracers, DOT supporters. So in as much as we've suffered with the disease, most of us have been trained. I've been lucky actually to be trained by Mike Harrington here. He picked me up when I was just starting, and his organization built my capacity. So most of us have taken whatever knowledge we got at international level, gone back to our countries and retrained other people who are now supporting at country level. So most of the time, again, we live and we work among the affected communities, so we still bring the first-hand information, and we also act as a bridge between the communities and the global efforts, the efforts that you are doing here. My constituencies back there would not know. So I come here, I listen to you, and I take this information back, and I also bring what is happening on the ground back to a meeting like this one. At country level, we are advocates at country level and at international level. For example, you want to come and do trials in Zambia and you're not able to, get through the governments, we can advocate on your behalf because we are the affected community, so we can demand for the service. So we are at country level and we are able to support you at that point. So I thought I should also share some of the channels of engagement that we can use. We've just set up what's called the African Coalition on Tuberculosis. This is a coalition of affected communities within Africa who have come together. We've started with 7 countries. So for example, if you want to do trials in a country, you can get in touch with the coalition and we can help support if you're having difficulties. We also have the community task force of the Stop TB Partnership. Though they need to deliver on their responsibilities here, we've been having a bit of problems with them, but we do have community participation on all the working groups. Community representatives on global health initiatives like the Global Fund Stop TB Partnership, these are people who we have representatives on all these that can help us with our work. International collaboration with international angels. Like I said, I work very closely with the Treatment Action Group, Result, and other groups in this room and that are not in this room. The African Union are also speeding up on their work. The presidents in the African Union have come up with a roadmap on shared responsibility and global solidarity for AIDS, TB, and malaria response in Africa. So our African presidents are also coming up with African solutions to these problems. So actually at the last UN meeting, I was just speaking with African presidents and they're moving forward and willing to support all the work that you'll be doing in the countries. There's also, most of us have heard of the SADC Declaration on TB in mining sector. The ministers of health in Southern Africa are also supporting, as well as other global civil society on TB. So our call to action. Our motto as affected community is nothing for us without us. We are people, like I said, who've had our capacity built, we can think for ourselves, so we can support. So we don't want people to go sit in their meetings and think for us when we can be around the table and think with you. We also need new drugs now. I know it takes a long time. I've heard a lot of these presentations that it takes a long time, but for us, we need the drugs now. And we need the FDCs and shorter regimens. When it comes to engagement as civil society or affected communities, we need meaningful engagement. We don't want to be rubber stamped. We don't want to just come and sit in a room and just, for you to just tick the box that somebody from the communities has come to this meeting. We need to be engaged meaningfully. And then we need engagement at all the levels. We don't want to be told, for example, when there's some mechanism that's being prepared and you're only told right at the end when the plan, if it's a plan or if it's a roadmap, you're only told when the final document has come out. We want to be engaged all the way through. And then timely feedback after trials and consultations. We've had people who've come into our countries with questionnaires to do researches or trials. After they do that, they leave the countries and they don't feedback. We'd be grateful if we're given the feedback as well. And then better treatment of trial participants, the ethics. I don't even want to go into that Pandora's box. There's so much that's done, but we'd be grateful if there's better treatment of the participants. And then point of care tool. It's very difficult when we don't have the point of care tool to get timely treatment, because in most cases, you have to go to the medical center or to the hospital. That's the only place where you have the tool, and it's difficult for you to start treatment. You might not have resources to get to the hospital. And then eliminate regulatory testing approval gap between rich countries and higher burden countries where new TB drugs and regimens are most needed. There's no point in getting a drug accepted in a rich country, but then it takes longer for it to be accepted in a poor country where it's needed the most. So I thought, just in conclusion, I wanted to say, as patients or patient representatives, once upon a time when you're a patient, the doctor just gives you the medication, they tell you what to do, but that has changed now. We are no longer mere recipients of care, but are now organized to take part in management of our diseases. There are a lot of patient groups out there in most of the African countries or the third world countries. There are a lot of TB patient groups that people can work with. So we want to take part in the management of our diseases, therefore supporting and feeding into the work being carried out by other stakeholders at other levels. The lives of TB patients, like I said before, depends on our combined efforts, on the efforts of everybody in this room. We also want to be part of the change we want to see in the world, and together we can. Thank you.